Good evening, everyone. The time is 7:45. Welcome to everyone who's watching us this evening. And we have for the first time tonight, we have Britt Landsman. Britt, turn on your camera. Let's wave at everyone. Danny Kadar, you being assisted tonight by Britt. I presume that means you're sitting in the same home or same place. You wearing a mask. Hello, Britt, welcome.
Hello, yes, Britt is a co-pilot. We now have evolved to having a co-pilot in the cockpit over here. So I'm the captain and she's the co-pilot. It's very exciting.
So how is your Airbus A380?
How does it work politically? Does the co-pilot just sit in the cockpit and do nothing in the Airbus for like years until they can actually have coffee or something?
So the co-pilot usually actually flies the plane while the pilot watches. But I learned something interesting this week. I don't know, Barry and Benji, I don't know if you actually know this, that it is civil aviation rules that if there's food on a plane, the pilot and the co-pilot have to eat different meals just in case one of them gets food poisoning.
Gosh, didn't know that. Good evening.
Evening, Barry. It looks like you have changed venues. We normally see your cupboards behind you.
Oh, okay. So I learned how to kind of blur the background.
Ah, okay. But that means we can't see all your Jewish Achiever Awards, which are usually on the wall behind you.
You want me to change it?
No,
okay.
no. A little blur can't hurt. We feel a little blurry ourselves sometimes. No, you can go back to blur. Back to blur. It's lovely to have you with us, though. This is, I think, the third time you've appeared with us talking about COVID and vaccines and all things related.
It might be a bit more than three.
Yeah, it could very well be. Yeah. So how's retirement going? Is it nice and quiet?
Sorry, how's the
retirement going?
Yeah, no. I'm just bored. I've got nothing to do. I'm trying to kind of work out what to do when I get up in the morning.
Howie, just from the WhatsApps that I send Barry, I can keep him very busy on multiple requests from multiple different institutions. And if that's retirement.
My wife says I'm out. She keeps me out of mischief anyway.
Look, it certainly kept you active during this COVID period, that's for sure.
Oh boy, yeah, absolutely. Yeah. No, you're right.
So Benji, how often do you send an answer to Barry, and is his answer, it's always okay unless I tell you otherwise, or it's always no unless I tell you otherwise?
No, you know that I've been sending lots of questions to him when I sort of can predict the reply. But it's always thoughtful, it's always measured, and always with, especially around the shuls, always with a deep sense of how important some of the prayers are and some of the activities are, which could seem in a way for someone who's not wired like Barry or his sensitivity. So it's been one of the most remarkable experiences just interacting with him and Professor Kramer before. It's just really been to see such expertise, and the replies are, it's like I feel so terrible, but it never seems like I'm disturbing Barry, or he's made so much time for the community. It's quite astounding.
But you never are disturbing me, Benji, I can tell you that. Always happy.
It feels like, depending on what answer you want to a question, depends on which rabbi you go to. So I don't know if maybe Benji has some questions for you, and if he wants a different response, he's got an alternative person.
No.
I always feel that I'm a bit of a spoil sport, unfortunately. I feel that I'm doing all the kind of negative things, but
that's not true.
So to all our guests busy joining us, Ido, welcome to you. Where do you join us from?
Thank you so much. I'm joining you from Rakefet. It's a small village in the Galilee. This is where I live.
Fantastic. And where do you work from home, or are you going into the office?
And unfortunately, I need to be at the office most of the week. It's in Tel Aviv. It's about 2 hours drive most of the time, but I take advantage of the drive to do a lot of phone calls, so it doesn't feel like a waste of time.
So you know, we joined from people all over the world. In fact, we did a webinar last night before Yom HaShoah, and we spoke about justice last night, and we had about 8,500 people watching us, and we got people who watch us from all over the world, from South America, from Central America. We've got people in Canada, United States, Panama, Argentina, a lot of people in England, some people in France watch us quite regularly. We've got people in Riyadh in Saudi Arabia and Bangkok. A lot of Israelis watch us. But of course, tonight is quite specific because South Africa's in quite a unique situation. We have 0.4% of our population currently vaccinated. That's a little different to kind of the world you live in on your side of the world.
Yes, actually, the situation now is, I just got back from a demonstration here, and most of the people didn't even wear masks. And it didn't feel odd at all. It felt like the ones with the masks felt like they are separated from the majority.
So we'll deal with this a little later, but what percentage of the Israeli population has now been vaccinated?
Over 80% of the potential population, which is the guys over 16 years of age, this is so over 80% out of them already got vaccinated.
Double doses.
Yeah, most of them with 2 doses.
And you're about to start with 12-year-olds to 16-year-olds if your government would actually pay Pfizer.
First of all, they are waiting for the FDA to approve it, and then they will. I think that there's a great debate about it because some of the leaders, the medical leaders of this event, are not so clear about what they think about it, if it's necessary to vaccinate the kids or not. So it will be a debate, and I think that the ratio or the number of kids that will get vaccinated will be a bit lower than what we were used to in the last few weeks or month.
But I see Ron's turned off his camera. I was going to ask him this question, but I'll throw it to you then, Barry. We generally, or Ron, you're back. We generally compare ourselves here to the world leaders, being Israel, 82% of the population being vaccinated. But if we compare ourselves to places like Canada or France, actually, they're not that much more advanced than we are.
Ron, do you want to answer that?
Oh, go for it, Prof. I got to be careful. I got to follow you on these questions, otherwise.
No, not at all, not at all. You know, Howard, the answer is yes and no. You know, many of the countries, and particularly middle-income countries around the world, have gone through vaccines which have not received stringent regulatory authority. Obviously, Israel stands out. That's clear. Israel is a world leader. There's no question about them, far advanced of any other country. But you know, it often gets thrown at us that many countries already started, they're very advanced. They're using vaccines which first of all haven't received stringent regulatory approval and would not be approved by our regulatory authority. It's not that they're bad vaccines. Don't get me wrong. I'm not saying that at all. They're probably very good vaccines, but they haven't gone through the loops of evaluation. And I think that our regulatory authority are very careful that what we do roll out is vaccines which are going to be both safe, proven to be safe and effective. So they're using vaccines from Russia and vaccines from Cuba, vaccines from China and so on, which would not be approved by us. But yet they're kind of saying, well, you know, they're rolling out. And, you know, I can go on for a long time. I'm sure you don't want me to, why there has been this delay, why there has been this lag. But I think the point is this, that we can only really kind of approve vaccines which are shown to be effective. Israel, of course, is an outstanding country. I mean, they're kind of separate from the rest of the world in the way that they've kind of gone about the vaccine, which I'm sure you're going to hear about this evening. But I don't think that any other country can really compare themselves to what has happened in Israel. They're a very specific case for a number of reasons. I'm sure Ido can go into more detail than I can, but if you want me to, I can start the ball rolling, but you probably don't have time.
So, I mean, we're going to talk to Ido about what has happened in Israel, what the effects of the vaccination program has been, and what advice do they have for us in terms of what worked and what didn't work. But Ron, when we look at some of the places in Europe, there are lockdowns taking place at the moment, severe lockdowns taking place in places like France, in Italy. I mean, the Germans took to the street to try to prevent a lockdown taking place. India's gone back into hard lockdown. This is the third wave in many, many countries. Are we definitely going to have a third wave in South Africa? Is it just a matter of time? Because our numbers at the moment are looking great. What yesterday was under 800, the day before that was under 500. We've gone through a period where our infection rates seem to be decreasing and decreasing. So can we maintain that, or are we definitely going to head into that third wave?
Yeah, I mean, those are tricky questions, Howie. I think, firstly, you got to look into what's driving the European outbreaks at the moment, and it's largely driven by the new variants, so the so-called B117 variant or the N501V1 variant. And we know, from the data, and I think your prof will attest to this, that the B117 variant is 50% the previous variant. And I think that's a warning for the world, and certainly happening across Europe. By the way, we're seeing a similar picture happen in the US at the moment as well, in and around the Northwest, Michigan. They've also seen an outbreak on the back of the 117 variant, despite high uptakes of vaccination. So we've got to be cautious of declaring victory too early on this. I think from a South Africa perspective, we've, as Discovery, have modeled sort of three scenarios that our actuaries are looking at in terms of the third wave. The first scenario is what we've called a second wave runoff, and the second wave runoff basically means we'll avoid a third wave. And the assumptions around that is that there's high levels of population immunity. There's on the back of big this first wave and second wave. That there's good population compliance, and that this whittles out. So that's one potential scenario. Then got an extreme scenario where driven primarily by low levels of population immunity, as well as super spreader events in and around Easter. And it's too early to call whether we've been successful over Easter or not. So we're watching the data very, very closely. In fact, spent some time with our actuaries this afternoon on the data, and we are seeing little upticks in places like Bloemfontein, for example. Seen a little uptick in Wynberg and Pretoria districts as an example, and we'll have to watch how those manifest now over the next few weeks. And if we've have seen super spreader events during the course of Easter, and given the delays in our vaccination program, then there is a chance of a significant third wave. And our actuaries project a third wave that would be roughly equivalent to the first wave peak. So a little bit too early to call. We'll certainly have a better view in a week or two's time.
Well, I think Stavros wants to confuse us because Greek Easter hasn't been yet, has it, Stavros? So you potentially spreading out the effects of Easter by having a second one.
So how we are celebrated Passover, right? So it's now time for Greek Easter.
You have to, first of all, we had Holy the week before. We've got Ramadan coming up very, very shortly. You can celebrate normal Easter. I'm sure that's a pejorative term, normal Easter, as well as Greek Easter. So you're having the best of all worlds.
We put differently, the Greeks are at least 4 weeks behind the curve, right? So flattening the curve. They're not flattening the curve, I can assure you.
I don't know if it's the curve or they're not flattering or just their stomachs. When is Greek Easter this year?
It's the first weekend in May.
Okay, so you do have a few weeks still to go.
So Howie, I'm stocking up on my matzah.
We all have leftovers stuff we can give you.
And then you will have Shavuot.
We can get you good. Well, the time has just gone 8 o'clock. Good evening. Welcome to everyone around the world. We've had thousands of people registering again for this evening. So whether you're watching us on YouTube, on Facebook, or on Zoom, tonight. A huge welcome to all of you. We want tonight to be a very practical evening. We don't want to waffle around. We want to get down to hard facts. We want to know, what can we learn about the Israeli experience with vaccinations? We want to understand, where must you register to get your vaccine? What are our medical aids going to do for us? What happens if you don't have medical aid? We want this to be as practical and difficult as possible, which is why I brought my hatchet man, Benji Porter, with me, because Benji is going to make sure that everyone actually answers the questions and answers them very shortly and sharply. But a huge welcome to all of you. If you're watching us on YouTube tonight, please click the like and subscribe button. That just allows us to communicate with you more easily. So we'd really appreciate it if you are on YouTube to click those like and subscribe buttons. If you're watching us on Facebook, Zoom, or YouTube, please tell us where in the world you are. And most importantly, if you're outside South Africa, we want to know the status of COVID and vaccinations in the countries in which you're actually watching. So we want to know, have you had one jab, no jabs? When are you likely to get a jab? And if you're in South Africa, we want to know what your expectations are. Like, if I told you that you could get inoculated only in November, would you be disappointed? What's in your actual head of when you're expecting to get a COVID-19 vaccine? And that's some of the information that we're going to be sharing tonight. So a huge welcome on behalf of the South African Jewish Report to the 86th webinar of lockdown. Benji, you're actually at the coast at the moment. We've dragged you off the beach to actually participate. So a huge thank you for doing that. What your expect?
Yeah, sorry, it's an absolute pleasure. And, you know, I think that if you and I think we've discussed vaccines. Stavros we've seen Stavros a lot in this business for South Africa. And it's a great honor to have everyone here and to have Ido, who is going to share the Israeli experience. But I know you and I feel both passionately about this, that this is not this is just a practical evening on where we're going, what we're doing. We don't want to debate any of the issues, how we got here or anything like that. My personal opinion, I heard Stavros say in previously that virology heavyweights made certain decisions, and we back them, and we're grateful to have those kind of experts in our environment. And so we are where we are, and we're excited to hear how we go forward.
So Benji, we're all going to help you. We want everyone to participate in this. So if you have any questions, post them into the Q&A section if you're on Zoom. So you'll see at the bottom of your screen, there's a Q&A section. We'll be looking there for all of your questions. If you're watching on Facebook or on YouTube, put them into the chat section, and Britt and Danny are going to be looking at that, and we'll be moving them across to Benji and myself to allow the panel to actually answer some of those questions. So a huge welcome to Danny Kadar and Britt Lansman, who's co-piloting this evening. Britt, turn on your camera and wave at everyone. Thanks, guys. Really appreciate all the efforts that you're going to tonight. And so just a quick reminder for those people who haven't collected the latest edition of the South African Jewish Report newspaper. The edition is out. It's on the streets. You can get it at Checkers or Pick and Pay or Spar or your local supermarket or your garage shop or your shul or wherever you go. CNA, exclusive books, you'll find. And it has this tragic story of this poor kid, Regenboom, who was shot in Melrose Arch during a robbery that took place on the weekend at Elegance Jewelers in Melrose Arch. And from what I understand, he's still in intensive care in hospital at the moment. So that's our cover story this week. If you haven't or can't get hold of the newspaper, you can always read it online, sajr.co.za. That's our website. It's been recently redone. It's looking absolutely spectacular. It's mobile friendly. So please, as well, go and look at sajr.co.za. And you can also download the full edition of the Jewish Report newspaper there. So Benji, just before we begin, exciting times generally in our country. There were briefings by the Minister of Health today. A lot of people tell me they couldn't understand a word of what he was actually saying. So I'm hoping that our panel tonight can actually decode some of this and we can actually put some of that interesting information down. But one of our sponsors for this evening is, in fact, Sheba Medical Center. So we're going to do just a quick advert from Sheba Medical Center. Ido, I'm sure you know them. They're rated in the top 10 hospitals in the world. Got this massive complex in Tel Aviv, one of the great research hospitals in the world. They're one of our sponsors this evening. We're going to watch a quick advert from them, and we're going to run a poll to ask you whether you would like to be on their mailing list. And they send out this remarkable information of some of the latest advances in technology and medicine happening around the world. So Danny, please close the video.
Only those who know how the day starts, but not how it ends. Who tried, succeeded, then tried again. Those who worried. Those who did not give up. Those who felt the weight of responsibility on their shoulders. Only those who saw the end and realized it was only the beginning. Who brought new life into the world, who've tasted victory, those who constantly seek out the next discovery, those who believed, only those who slept 2 hours a night, who removed all social barriers, who kept their cool, those who dared, supported, protected, laughed, made others laugh, pioneered. Only those who broke new ground, who wake up every morning to carve a new path. Only they understand hope has no boundaries. Sheba Tel HaShomer, City of Health.
So if anyone would like to get onto the mailing list and hear about the latest developments in science and technology coming out of probably one of the most innovative hospitals and medical centers in the world, we've put up a poll. So for those people on Zoom, you can click on yes, I'd like to hear a little more, get your newsletter from Sheba. I see the numbers of climbing, 85, 93, 126 at the moment. Danny, I presume that our people on YouTube and Facebook as well have a method that you've posted on as well that allows them to get onto the mailing list from Sheba. I see like we're now on to 278 people who want to be on the mailing list. It's actually such a great story to have really one of the top 10 medical and research institutions in the world in a place like Sheba. Ido, do you guys work with Sheba? I presume you're with Maccabi Medical Aid. I presume there's a good relationship that you guys have with the Sheba Medical Center?
Yes, for sure. Part of or half of the residents in the Dan area in Tel Aviv and all the cities around Tel Aviv are members at Maccabi. So Sheba is one of our main hospitals that we stay in very close contact with.
Fantastic. So if you haven't yet, we're going to leave the poll up for another 20 seconds. On Zoom alone, we're now up to 370 odd people who've requested to be on the mailing list of Sheba. And we're going to close that literally in 5 seconds. And while we do that, we're going to ask Barry, Stavros, and Ron to turn off their cameras. And Ido, tonight, you join us from Maccabi Medical Aid in Tel Aviv. You have, in fact, a relationship with Discovery Health in South Africa. Tell us very briefly, a few seconds about the medical aid and how many people, how many lives do you actually cover?
Well, in Israel, there are 4 health funds, non-profit health funds budgeted by the government. Maccabi have about 2.4 million members that we provide services to each day. most of the services we provide them in-house, and part of it we do an outsource, like buying services from Sheba. And now with all the Corona and all the COVID, we had 4 frontiers. The first one is to take tests, COVID tests from millions of people. And for that, we developed a booth. Maybe you saw it in some of the international outlets, a booth that is with 2 huge gloves, so that the staff member does not need to change his clothes from patient to patient. It worked amazing. The second frontier was to treat the patient. 98% of the positive patients were hospitalized at home and got all the services from us. The third frontier was still to treat all the morbidities, all the routine morbidities that were maybe applauding to the COVID, because all the focus went to the COVID and we forgot about diabetes, cancer, and everything else. So we didn't forget, and we had to treat these patients as well. And of course, the fourth frontier was the vaccination rollout, which was, I assume, the largest ever civil event in Israel, even more than the Aliyah that was from former Soviet Union in the 90s. It was amazing, amazing event. I think that it started on the 20th of December, and for a week, at least a week, I think I didn't have one decent meal or more than 4 hours sleeping. It was like a week that started very early on Sunday and didn't ended until a week or more later. But it was amazing, an amazing experience, and I'm very much proud of the success, not just of Maccabi, but all the 4 health funds in Israel.
So Ido, you're going to in fact run us through some data of what are the results of the vaccination campaign, and then we're going to come back and ask you some questions about the lessons learned and the advice that you can share with us about what worked and what could be done better.
I'll share my screen if it's okay with you.
Absolutely.
Just a second. And I'll also try to share, just a second. I want to share voice as well. Share sound, great. Okay, so a word about myself. I used to work for the Ministry of Health, and before that for one of the Israeli hospitals, and for the past nearly 2 decades I'm working for Maccabi, and I also serve as venture partner at an live Israeli health tech fund, which Maccabi is part of it. I also consulted UNICEF in Ukraine for quite a long time. I'll try to move forward with the presentation. Something is not running well. Just a second. Okay, so results first. Usually you get to the result at the end, but let's start with the results. This is the number of doses per 100 people, and Israel is still leading. But I'm very happy to see that many other countries are closing the gap and getting close to us. It's very good. And with contagious epidemics, you cannot win alone, because it doesn't really matter if Israel will win it if the other countries will not. So I'm very happy with these numbers. I'm checking it every week, and the gap is closing very fast, which is good. And here's the ratio of people getting vaccinated with 2 doses. And thanks to many kids that we have in Israel and the relatively low age, we will not reach any higher than that, maybe few more points, but not any higher than that. In Israel, we have nearly 10 million people, nearly 3 million kids. So at least now, the target population is 7 million. Or 70%, and we are very close to 60% coverage, which is great considering the numbers here. And I want to, I have few minutes, so I made a very short presentation, and I will try to run very fast. I suggest you will imagine a braid of hair. As you can see, I'm not doing a lot of braids to myself, but if you take you need to take 3 groups of hair to do this braid, and you need them to be at the same length, or at least coordinated between each other. So the first one is, of course, logistics. You have to have great compounds. Everything needs to run carefully and perfectly. And you have to have supply. This applause goes to the government, not to us. They made it real. And the last group of hair, or group of challenges, is the public engagement. Because you can have everything ready, but the public will not come. So we decided to do actually 4 kinds of vaccination compounds. The first one, the smallest one, is a mobile unit. Here it's parked next to Holmes Place, only with 1 station inside, but it can go wherever we want, which is very good. Also, to come to very small villages or inside neighborhoods, it's very good. The second, or the next level, is a caravan, a bit heavier, with 2 vaccination units or stations, a bit heavier, but still mobile, and it's a combination, let's say. The third one is our large compounds, mainly in big basketball halls. This one is in the basketball hall of Hapoel Tel Aviv. Although we are Maccabi and the Hapoel is the greatest enemy, they let us use the basketball hall, and this is in the lobby. Usually people buy here the popcorn and Coca-Cola and hamburger, but now it became much more healthy. So in a compound like this one, we have 13 stations, and it's a very big one. We can vaccinate nearly 1,500 people per day, working 12 hours a day. And the last one is a drive-in. We had one like this in Israel. It is in the parking lot of a very big football stadium in Haifa, in the city of Haifa, in the north part of Israel. Working amazingly. People are coming with their car and getting vaccinated inside their car. You will see it soon in a short movie.
They're calling it Operation Back to Life. Not the most catchy of names, but this extraordinary logistical success, with promotional videos from the country's health providers, is just 3 weeks in already the envy of the world. If Israel is accused sometimes of varnishing its image with slick PR, here the reality does appear to match the gloss. The country has more than 300 drive-through vaccination centres, and in the northern city of Haifa, the benefits are obvious. Natalie Roynick is a vaccine recipient and a doctor.
As you can see, it's working perfectly. I just came here, and here I am, just getting inside.
I hope you were able to hear the sound as well. Okay, so one of the major issues after you saw the issue of the logistics is to make people come. You can make the greatest cake, you can have your house decorated for this birthday, but no one will come. And this was a great concern in Israel. For many weeks, we were sure that people will not come. And we put a lot of efforts in creating a demand, or at least creating plans to create demand. But once the lines were open to schedule appointments, we were surprised from the level of demand, which was amazingly high. So at least we bypassed this challenge. But nevertheless, if you want to achieve the highest numbers as we have now, I just opened my cell phone to see the latest numbers. So we're talking about 84% of the relevant population already got vaccinated, And if you take the above 50 of age, the average is 93.1%, 93.1% of all the people above 50. In order to reach these high numbers, you have to have great engagement with the people. Not all of it is demand. Some of these people who got vaccinated, we made them come in many ways. First of all, we had to make the scheduling of the appointment very easy, very accessible. So it can be done by telephone on the left side here. It can be done automatically or digitally. By digitally, I mean that I'm getting inside the app and schedule my appointment. Here, we send people an SMS saying, you have an appointment. We set an appointment for you already. If you don't want to come, please press here. This small push made thousands of people come and get vaccinated. It's like, well, I have already an appointment. They are keeping a dose for me. I really don't feel convenient to cancel it, so I will come. And I must say that one of our major success was this scheduling of appointments and not a walk-in clinics or a walk-in vaccinations, because people were scheduled for 9 a.m. At 9 a.m. they got the vaccination. And this wow that we created really made them feel so good. They talked with their friends, with their family, and people felt that something is different, because in Israel, you are not used to such a level of service. So this very good atmosphere really helped the success of the event. Another thing that gave us a lot of fuel to this burning engine was the remarkable coverage that we got from hundreds or at least tens of outlets all around the world, at least in 15 languages, but we really cannot monitor all of them. So hundreds of Maccabi members saw most of the days, they saw TV crews in our compounds. Many people just, the TV crew went to the patients and asked them, how do you feel? And in one of our presentations, I called it, let my people talk. I really didn't intervene because I was sure that the patients are going to say good words about the event and about the vaccination rollout. So at least the PR tip that I can give is, if everything goes good, just let your people talk and they will be the best ambassadors ever. So I hope I made it on time. This was my very short and brief presentation, and I have a much longer version if you want, but for now I think it's enough.
So Ido, can you share with us, what are the results that you've seen? You've now got an enormous percentage of the population vaccinated. You say 93.1% of everyone over the age of 50. What are you seeing in terms of infection rates? What are you seeing in terms of severe infection, hospitalization, and death from COVID?
All the criteria that you just said are decreasing rapidly. The letter R that we set as the number of patients, the number of positive cases that each positive patient contracts with. This R is about half, or 0.6, meaning that each positive patient does not even pass the disease to a single person, less than one single person, which is very good. For many days, it was a lot above 1. Second criteria is the number of positive cases each day. This number in the highest peaks was, if I remember correctly, 9,000 per day. And now we are talking about, if I remember correctly, 500-600 per day, very low. the number of severe cases at hospital is very low in comparison to the highest peaks of the event. So we really feel that the disease is starting to be contained and getting smaller and smaller. Still, all the troops are in the positions, and we really don't know what will happen next. We just had the Leil HaSeder. We don't know what will be the outcomes of that. We are going to have Yom HaAtzmaut, the Independence Day, and families are getting together, friends are getting together. We don't know what will be the consequences of that. And of course, Ramadan and Pascha and soon Shavuot, and the education system that is going back to routine. We are monitoring it very carefully and hoping not to see any number getting higher than it is now.
Ido, when we met to discuss this, you spoke through the idea that you had in the beginning a priority list, and that priority list was actually closely followed. What advice would you give us in terms of setting that priority list and ensuring people don't jump the queue?
I think that priority groups are essential, not just because of supply. Even if you have full supply for all your target population, it will be wiser to start with the high risk. In Israel, we started with 60 and above. And the first group was 60 and above, medical staff, oncology patients, active or non-active, and immunosuppressed patients. This was the first risk group. Then it got lower and lower by ages, 55, 50, 45, 40. The next group after 40 was 16 to 18. And just then it was open to 18 and above. I think that what happened is people felt like fear of missing out, FOMO. The 59-year-old or the 55 felt that he's not eligible. It just made him want it even more. So opening it to risk groups first and then widening the groups can be a good, I would take the chance to say, a positive manipulation to create better demand.
So it'll also walk us through. You say you make an appointment, you arrive. You actually had a wonderful phrase that you explained to the fact, because anyone who's been to Israel knows that Israelis don't stand in line, they don't queue, they push each other out of the way. That's just part of the national culture. You described the fact that Israelis for the first time actually listened to the rules, actually adhere to everything. No one tried to schmuggel their way in front of everyone. And you had a very interesting phrase that you described it as.
Well, yeah, I think that it was the British mutation, the British variant. We became polite, and I hope it's not like a side effect of the COVID. But if to be honest, I think that what made the effect is like the first impression that people had, because we were very strict, even stubborn. People called us bunker. Because if you didn't schedule an appointment, we didn't let you in. And even when other health funds made some walk-in vaccination or told you, well, you're 58, you can come inside, we were very strict. And the other side was that we had a contract, an unwritten contract, of course, with our patients. And we told them, look, we ensure you that you will have a vaccination. Don't worry. Please come at 9:15 and we will get you in at 9:15. And when they came with no expectations, because in Israel, it's not the level of services you're used to, and they saw that it's 9:14 and they're already in, and at 9:15 they sit in the station and getting the jab, they understood that we stood in our, or we met our obligation. So they came with their obligation and they sat quietly for 15 minutes at the other side of the compound after getting vaccinated. They didn't try to run away. They told their friends that everything is running so good. So I think that if you create this unwritten contract and you promise something and then you stand up to your promise, we react as human beings, we react very positively to this kind of behavior.
Did you develop like a metrics around how many vaccines should happen in an hour, how many people you can see, where you were going to see it? You must have had lots of learnings from that process.
For sure. The supply is very sensitive in this issue because like when you order biscuits, it can be eaten in the first day or in 1 week or in 1 month even because it's dry supply. But when you order at least the Pfizer vaccination, once it left the -70 Celsius refrigerators, you have 4 days to use it, not more. What we did is we created scheduled appointments for 3 days to finish this supply. So we ordered thousands of bottles for Sunday morning to one of our largest compounds, and we had like 1,000 bottles. It's like 6,000 people. We had 6,000 people for the next 3 days, Sunday, Monday, Tuesday. And we knew after a few days, we saw another issue from this British variant of being polite. There were no-shows. People came. Usually in Israel, for the doctor, you have at least 15% of no-show. To the vaccination in the first 2 months, we had 1.5%. 1.5%. It's actually zero. So we knew that if we invited 6,000 people, 6,000 people will come. And if not, we have another day to use this supply, so it's not a problem. Another manipulation, let's say, that we did is when we had a compound of 13 stations, nursing stations, we made scheduling only for 12. So we always had the logistics a bit above the demand. So if we saw a waiting line, we could cut it very rapidly. If an old man came with his foreign caregiver, we were able to vaccinate the caregiver even if he didn't have a scheduled appointment. This was the only group that we did that way. So things ran good. I must say that we made a great mistake in the planning, at least. We planned to vaccinate 25,000 patients per day. And after, I think, the 3rd or the 4th day, we saw that we underestimated the abilities, the demand, and we set a goal of double, of 50,000 per day. And at the highest days, we reached even 53,000 per day only in Maccabi. And we know that we are able to do 60,000. And if we will work 24 hours a day, the number is actually 100,000 is a real number.
So Ido, just tell us, how long does it take to give a vaccination to people? If you have enough supply, what's the throughput you can actually do? A nurse or a doctor, how long does it take them to actually give the jab? And if you could add on, I see one of the people watching us has just asked about side effects and anaphylactic reactions of people who had the vaccine.
One of the side effects is that I gained a few pounds. But I'm working on it. It took us, we planned on 8 minutes per patient. And after the first few thousand, we cut it by 2 minutes. So it's 6 minutes per patient. And you can make many things that even can shorter this time. first of all, try to give the vaccination mission to people who are trained to give vaccinations. It's more like paramedics, nurses, and a bit less to the doctors, not because they are not good, because nurses are vaccinating much more people on routine, so they will do it probably faster. Another thing that can be done in Israel, it cannot be done because of regulation, but I'm not familiar with the regulation in South Africa. If you will put next to each nurse like an assistant, that he will do all the documentation, then you can cut the time even more, even less than 6 minutes.
A number of our viewers have asked, and maybe you might know this, you might not. Do you know whether the Israeli government are going to accept all the different vaccinations, all the different? The specific question was, do you know if they'll accept J&J as a vaccine when they're allowing people into the country?
There was a debate about getting Moderna inside, and Israel did buy few hundred of thousands of Moderna, and we advised, we as HMOs, we as executing of this vaccination rollout, we advised the government not to use any other sense except the Pfizer. Because we started with Pfizer, we have millions of doses given. We don't want to mix and to create problems in a compound, having half of that, a lot of confusion can be done. We prefer to continue with the Pfizer.
Actually, the question's a little bit different. If someone's been vaccinated with the J&J vaccine, do you think that there would be a problem when they want to enter Israel at some stage?
The issue will not be that. The issue will be if Israel is have confidence with the fact that he was vaccinated, then probably Moderna, J&J, Astra will be eligible. And that was asked also about the side effects.
Yeah, what sort of anaphylactic reactions did people have? What percentage? What were the side effects?
We are prepared to very severe side effects, and I must say that we didn't experience any. On each station, on each table, we have an adrenaline syringe and all the relevant equipment, but we nearly didn't use it at all, which is very good. We are keeping a very, very close monitoring on that. Also in the compounds themselves, but also after one getting vaccinated, at least thousands of them are getting a poll. How did you feel after getting vaccinated? And many, many other questions. What we did see is that many people after the first vaccination have some pain in their shoulder, but after the second vaccination, many people went to bed for 2 days with all the symptoms like flu-like symptoms. My wife suffered for 2 days from flu-like symptoms, the worst that can be. I didn't. The word is that if your immune system is better, mainly if you're younger, you will suffer a bit more. So she's laughing about me because we're in the same age. And again, she has the advantage. We had an issue. The first day of vaccination, a pharmacist of Maccabi went to get vaccinated, and by mistake, he was given an undiluted bottle. So actually, he got 5 times or a dose of 5 doses. And all the media was about it, and we felt that it may be an event that will harm the whole process. And we did some things that made it disappear. So the media did report about it, but we were very open and very transparent, And this guy was amazingly nice, and he got interviewed in many places, and he even laughed about it. So it went, people understood that mistakes can be done and everything is okay. And we did find out that in the first steps of Pfizer research, they started giving the big dose for the participants in the research, 5 times than what we got. So we told it also to the media, and I think that the transparency made a difference.
There are many Israelis living in South Africa, or South Africans who also have Israeli citizenship and homes in Israel. If they arrive in Israel, can they get a vaccine?
This is a very good question. Who is eligible for the vaccination in Israel are Israeli citizens and residents that are members of one of the 4 health funds. If you are not, what you can do is you can purchase, since there are many foreign students in Israel, foreign diplomats, foreign reporters, we also, even if we're non-profit, we offer them some kind of health insurance program that they can buy for themselves, and then they can get also the vaccination for themselves.
So the reason why I asked that question is because one of our sponsors this evening is Hold Real Estate, and there are many, many South Africans who in fact have purchased properties in Israel through Hold Real Estate. They hold your hand right from the beginning, right the way through the entire process, the building, the construction, the banking, and helping you set up with a second home in Israel. So Danny, can we quickly look at an advert from Hold, please? So we're going to run a very quick poll for people for 2 things. Number one, if you'd like to hear more from Hold, please click on the link on the poll that Danny's about to run for us right now. But also, really importantly, Julian Nathan from Hold is in South Africa at the moment. He's been fully vaccinated. Ido, I have no doubt that he's one of your clients. So, so Julian's in South Africa. If you would like to have a cup of coffee with him and discuss the possibility of purchasing a second home in Israel, this is an absolute ideal time to click on the link to say, yeah, I'd like to schedule a free consultation with Julian Nathan while he's in South Africa, and have a cup of coffee together and talk about opportunities of buying a home in somewhere in Israel. A lot of South Africans seem to like Renana. As you know, they refer to it as Renana Fontaine. Very South African area, and Ir Yamin has become very popular as well with people who want to live near the beach. And for people looking for cheap alternatives, places like Ramat Beit Shemesh, very, very popular as well. So if you would like to meet with Julian while he's in South Africa, if you would like to be on the whole database so they can send you some more information, we're going to keep that poll open for about another 20 seconds. And while we do that, Ido, thank you so much for joining us this evening. It really is such an honor to hear about the remarkable success that all of Israel has been involved in this process. And more importantly, your willingness to share with all of us in South Africa, seeing we're at 0.4% of our population being vaccinated. We've got a long way to go to catch up. Yes. But the more we can learn now and the more we can refine our rollout program, the better it will be for all South Africans. So thank you for joining us this evening. You're welcome to stay if you want to. If you want to go spend time with your much younger wife, please feel free to do that as well. But we really appreciate your coming through.
Thank you so much. And I wish you all a very happy Independence Day next week. And may this be an independence also from this epidemic.
Ido, before you go, there's just one question that's coming through. Did Israel vaccinate pregnant women?
Yes, for sure. For the first weeks, we didn't, but then we decided to do so since we saw a high number of pregnant women getting very severely sick. And it went great, no side effects. And I think that we achieved already 75% of the pregnant women that we know about, at least in Maccabi. And hopefully we will reach even more.
Right.
And this is actually Exhibit A. This is the bottle I got.
Right here. We'll take it.
Cool, fantastic. Ido, thank you very much. And with that, let's ask Professor Barry Schoub, Dr. Ron Whelan, and Dr. Stavros Nicolaou to turn on their cameras and let's start talking about South Africa. I think what do you think of that, Barry?
Well, what can I say? You know, Israel is really a kind of model for the world. And I think this is why Pfizer actually selected Israel, because Israel has got such an excellent infrastructure, excellent documenting facility. And I think this is why, you know, in Israel really kind of can do the kind of nationwide implementation study. Nationwide, they can kind of show how vaccination can be done from an implementation point of view, how it can be done from an administration point of view, and importantly, how it can show how effective the vaccine is. Because there's just so much knowledge, and I'm sure from a scientific point of view, there's just such a plethora now of scientific information which are going to come from the Israeli nationwide rollout. So yeah.
Barry, let's actually start there with our quick fire question and answer. How effective have the Israelis proved the vaccines to be?
Yeah, well, you know, there's been quite a recent study published in New England Journal of Medicine. They've shown efficacy of close on of 90%, which is really what was found in the original trials. So it just showed that in a field situation, in other words, in a natural situation, you can show more or less the same kind of efficacy as was shown in the trials. This is a remarkably effective vaccine. And I think the Israeli rollout experiment, I say, or I shouldn't say experiment, that's the wrong word. The implementation study demonstrated it.
I know that Benji is going to ask Stavros about how many vaccines we're expecting when in the country. But just before he does that, can you tell us, SAPRA, the South African Health Products Regulatory Authority, what vaccines have been approved by them so far for South Africa?
Up to now, there are two vaccines which have been approved. The Pfizer vaccine, as you probably saw in the news recently, and of course the J&J, the Johnson & Johnson. The Johnson & Johnson initially was approved just for the implementation study, what we call a 3B, but now it has been approved for emergency use authorization with some kind of caveats. But I don't think that's really important for this discussion. Essentially,
the big difference is Pfizer requires 2 vaccines, Johnson & Johnson only requires 1 dose.
Correct, exactly that.
And Prof, how effective are both of them?
They are very effective. I mean, you know, the kind of big question in South Africa we've got to ask is not how effective it is globally, how effective it is against the variant, the B1.351 variant or 501V2 variant. That's a critical question. And the even more critical question is, how effective is it to prevent severe disease caused by that particular variant? And these are the two vaccines, in the case of Johnson & Johnson, showed in the clinical trial to be effective. It's gone up now to about in the mid-60s%, which prevents mild to moderate infection, and 85%, that's a critical one, preventing severe infection with the Johnson & Johnson against the variant. The Pfizer, we haven't had really a clinical trial. There's been a recent analysis, but it's very small, showing very effective against severe infection, but really only looking at 6 to 8 cases. So it's a small thing, but there's a lot of other ancillary scientific biological information which kind of shows that Pfizer will behave very similarly against the variant.
Thank you. Stavros, firstly, before you answer our questions, I just to say, as I said earlier, Howie and I have watched you in Business for South Africa and seen your leadership, and just once again, we're lucky to have you in our country and part of the leadership team of our country and driving this. So just a personal thank you from both of us. So Stav, just give us a breakdown. When we're receiving these wonderfully effective vaccines?
Firstly, Howie and Benji, thanks very much for inviting me back. I wasn't sure if I'd get a return. After all the mischief last time.
That was your Zagesund at the end that got you over the line.
I suspected it might be that. But, it's indeed a great pleasure to be back here again. When we last spoke, we knew that we would probably have sufficient vaccines, but we had an immense timing issue. So we knew a lot of the vaccines could start arriving in Q3 and Q4. So we always had this gap in Q2, which is the quarter that we're in presently. So I think one of the positives that have happened in the past few weeks is that we have started bridging that gap somewhat, not entirely, but at least we're getting full line of sight and visibility of a supply pipeline. So let me take you through that pipeline, and let me preface what I'm going to say by repeating what Barry said earlier, that right now we have two vaccines that are registered by SAPRA. They were emergency or expedited review, or they underwent an expedited review. It's a J&J and the Pfizer options, as you've heard. There are various other vaccines that are in for registration, and of course we'll wait and see whether they are registered or not, and the timing thereof. So the two options that we have right now, we know that in Q1, through the implementation phase 3B study Barry spoke about earlier, we know that 500,000 doses of J&J became or will become available. So 300,000 of those have been received thus far. We await a further 200,000. That gives you 500,000 doses in Q1, early Q2, all intended for healthcare workers. We know we need to vaccinate between 1 million to 1.2 million healthcare workers. So around 50% of that will be covered through the J&J implementation study stock. After that, we move into commercial inventory or commercial stock using the two options of Pfizer and J&J in Q2. I'm being rather precise because there's been a lot of ambiguity out there and not full, people say we're not getting a full picture. So I am going to be a little verbose here because I want to give you an exacting or a precise picture of what is anticipated. So I'm moving into Q2. In Q2, we're expecting 5.5 million doses of Pfizer.
Just tell us, what does Q2 mean to our viewer?
So Q2 is 1st of April to 30th of June this year. So it's that 3-month period. So we are expecting in this quarter 5.5 million doses of Pfizer. Commencing, supply will commence on about the 24th of April. And the rest will be received on a phased basis over the remaining 2.5 months thereafter. Then we're expecting the remaining 200,000 J&J doses that will take us up to the 500,000. That's also expected during April and early May. This is clinical trial stock. It's not commercial stock. So we're going to complete the implementation study on the healthcare workers, reach the 500,000 donated clinical trial stock material from J&J by mid-May. Then there's a further amount of 2.8 million doses of commercial J&J stock, which supply commences on approximately the 23rd of April. And that stock is likely to be supplied out of South African manufacture, the majority, if not all of it. And we know that we know this because this is what the minister spoke about today, the first 1.1 million doses of J&J, that first initial supply will be 1.1 million of the 2.8. And as I said, supply commences in late April and ends in early to mid-May of the 1.1. So let me give you a consolidated view. I think it was important that I give you the breakdown. As many people have been asking for precise dates, and I don't think we can be more precise than that right now. There is still, there is still things that need to be tied up. But let me give you the consolidated picture. So that means we've received in Q1, January to the end of March, 300,000 J&J clinical trial implementation study doses. And then if you combine Pfizer and J&J, you will have sufficient stock to vaccinate around 5.6 million people. Now, why is that? It's because Pfizer requires 2 doses, J&J requires 1 dose. So we're expecting as a country to receive and land in South Africa sufficient stock in Q2 to vaccinate the equivalent of approximately 5.7 million lives, as we call it, in the healthcare environment. Then I'm going to be less verbose with respect to Q3. With Q3, with what is planned between J&J and Pfizer, and of course this assumes that we don't have other options coming into the mix, and I'm sure you will have other options. As I indicated earlier, some of these are in for registration, etc. But supposing we just stick to the script of Pfizer and J&J, we would have sufficient to vaccinate around 18.3 million lives in Q3. Okay, and then so we move on and we move forward from there. So what's changed from when we last spoke? I think we've got better visibility and granularity of the supply pipeline. And I think that the focus and emphasis will now start shifting to the second challenge. We always had 2 challenges. The one was landing the stock. The second challenge is rolling out and administering the vaccine. And that's an immense challenge. I'm sure you'll cover that with later questions. But just to give an indication that we need to vaccinate between phase 1, which is the healthcare workers, and phase 2, approximately 17 to 18 million lives. So that's the challenge. And it's going to mean, lastly, that we have to vaccinate as a country across private and public sector, assembling all our resources that we have, between 250 to 300,000 people a day would have to be vaccinated on a sustainable basis for us to reach that target. And I haven't covered phase 3 as yet, which will be the remainder of the population. And happy to discuss who fits into what phase a little later on. Thanks very much.
Let's actually go to this. Your Yiddish is better than mine, so let's get down to tachlis. People want to know, phase 1 healthcare workers, that's underway at the moment, and will probably continue in parallel together with phase 2. Phase 2 is people over the age of 60, people with comorbidities. We'll talk about who's in phase 2 in a second. But when does phase 2 actually begin?
Okay, so Harvey, we have an estimated date, and we were discussing this as recently as yesterday on a call with the minister and his team. The estimated date is the middle of May. I think we will have a more precise date next time we meet them, which is quite soon. But I would be working around mid-May for when we would have completed phase 1, the healthcare workers, and would commence with the first grouping of phase 2. Now, Prof. Schoub and Ron can also expand a little more on this, but you will all know that the intention is to vaccinate between 37 to 40 million South Africans. I say South Africans because there's also a component of migrants that are likely to be vaccinated, and maybe Prof. Schoub can expand a bit more on that. But I'm specifically saying South Africans, 37 to 40 million over a 12 to 15 month period, which would end in Q2 next year. And the sequencing of that is over 3 phases. Phase 1, healthcare workers, as you've heard, that's about 1 million to 1.2 million South Africans. Phase 2, which is the phase we'll move into from mid-May onwards, would cover the following population groups or segments. It would cover your elderly, your comorbid, and the definitions of who is comorbid and the different levels of risk in that comorbid grouping. And then you've got your essential workers, and then people that work or function in congregate settings. So that's the population group and or segments for phase 2. But because we've recognized, and then phase 3 is the remainder of the population, roughly 22 million people. So on just sticking on thematically on phase 2 for the moment, we realized because there is a timing issue with the supply of vaccines in phase 2 and also our capability to ramp up to 250 to 300,000, there's also a recognition that we've got to sequence things on a risk stratified basis in phase 2. So the first grouping, and Prof. Barry can correct me or complement what I'm going to say here, the first grouping in phase 2 that would go is the elderly, age 60 and above, because there is a high correlation between mortality rates and the elderly, first instance. In the second instance, there's a correlation between the elderly and comorbid states. So there's a strong correlation between the two, and there's good science to indicate why, from a sequencing point of view, your elderly aged initially 60 and above should go first.
So let's actually throw that threat to Barry. So Barry, will 80-year-olds go before 70-year-olds, or is it all people over 60 in one shot?
No,
Sorry,
I think
can I add to that? Sorry, Barry, can I add just from what I understand from Stavros, is it going to work that all the healthcare workers, no matter what, are going to be finished first, and then we're going to go into the elderly, or are there going to be concurrent process there? Yeah.
Well, first of all, I must say that our Ministerial Advisory Committee is not directly involved in the actual rollout. We have a working group which has given advice. That advice doesn't necessarily have to be taken to the letter. It is mainly taken. Most of it is. So I can really speak about the advice. What's actually implemented might be slightly tweaked from that. But as Stavros has just mentioned, and I think it's very obvious, the main determinant of morbidity and mortality, in other words, the load on the hospitals, is age. Age overrules all other things, overrules more comorbidities, etc., etc. So age has really been the main determinant. And they've actually fractionated age. And this is where we actually have recommended from our Ministerial Advisory Committee, that there will be a sequencing on age. And we've actually advised on a scoring system. And to give you some idea, I've got it in front of me here. If you're over 70, well, we haven't done the 90-year-olds, but just to give you some idea of, the relative scoring, over 70, you get a score of 16. 60 to 70, you get a score of 8. 50 to 60, a score of 4. And 40 to 50, a score of 2. And to give you some idea of the comorbidities, the diabetics are a score of 4. If you are a renal disease, a severe renal disease, again, a score of 4. Cancer, the blood-based cancer, what you call hematology cancer, is 4. Other cancers, 2. So you can see age is at a much, much higher score than those comorbidities. And age will really be the primary determinant. And to answer your question, Benji, yes, sequencing according to those age branches. The advantage of age also is not just from that point of view, which is obviously the main thing, but also age is the most easy to kind of administer. You know, you just produce your ID card, you can see immediately what your age is. You don't have to prove what comorbidity you've got.
So Barry, sorry, when I register, will it ask me these questions? Will it say, what is your age? Do you have any of the following diseases? And do I then come out with a score? And that depends on when I'm called up for a vaccine.
That's what we've recommended. Correct. Yeah, that's right.
So exactly. Ron, maybe we can turn to you on that. Have you seen the system? What system's going to be used?
Yeah, I mean, firstly, evening, Howie, Benji. Great to be on the call. Stavros mentioned, this is always a fun discussion to be part of. Thank you for hosting us. So the primary system in South Africa will still be the EVDS system, the electronic vaccination data system, developed by the National Department of Health, with input from B4SA and the private sector. That system will be responsible for registration, as you rightly mentioned, and the registration will include your specific details around where you live, so that we're able to locate your vaccination sites for you. It'll include details around your underlying medical conditions, medical aid details. We haven't seen the final fields yet. The NDOH was finalizing the fields for the EVDS yesterday. But as far as we know, there'll be those broad categories. The intention then is for EVDS, as Barry mentions, is to prioritize the population based on risk factors. And as Barry rightly mentions, the major risk factor is age. There's just no doubt about it. We certainly see that across the discovery data. So for instance, if you're between the ages of 70 and 90 and you get COVID, you've got somewhere between a 50 and 60% chance of being admitted to hospital. So we are strong advocates for age as a prioritization criteria, both in reducing morbidity or hospitalization, as well as reducing mortality. I think many countries have followed a similar approach, as you would have heard from Israel colleagues as well.
So Ron, can I just ask, over the last few days, there have been a few emails flying around. The one is something that said everyone over the age of 65 is now eligible to register on the electronic database system that government put out. Is that correct, or is that fake news?
I'm going to be honest with you, Howie. I don't know. My wife came into my office this afternoon with that very same SMS. And to the best of our knowledge, the EVDS system has not been formally launched for phase 2 yet. So that rollout has not happened. We'll obviously check with the NDOH over the next few days. I don't know whether Stavros or Barry have any later information on that, but certainly from what
I'll ask him to answer that in a question, but I'm going to add in one additional thing. Is people seem to be getting emails at the moment from the CDC, the American CDC, asking them to register and provide all sorts of information, a clear phishing scam to try extract information out of people. There is no reason, am I correct in saying, there is no reason why anyone in South Africa should ever receive an email or provide information to someone claiming to be from the Center for Disease Control in America?
Absolutely no reason.
Absolutely
no reason. Please be very cautious. There is a lot of fake media doing the rounds. There's a lot of phishing scams doing the round. Be very, very cautious that any communication you receive is from a validated source. Crucial. I think where the reputable sources are in South Africa. So strongly encourage you to follow those channels.
Barry, did you want to?
Yeah, I know. I was just going to amplify what Ron has just said, that the EVDS system at the moment is limited to healthcare workers. Now, I know that a number of people who are not healthcare workers have kind of registered on it. Now, in the EVDS, they'll ask you for your medical registration number, et cetera, et cetera. So I think if you don't fill that in, I think that registration is probably going to not be of any effect anyway. So I think that the EVDS for the phase 2 hasn't yet opened. My information from our meeting this afternoon, in fact, was that it is about to be, but it hasn't yet been opened.
So maybe this is a question for the panel. I'm comfortable for anyone to answer. It's been, I would say, and on the Business for South Africa, I think it was mentioned as well, quite challenging to ensure frontline healthcare workers went before, let's say, non-frontline healthcare workers, which creates like an environment where you think there's going to be a scarcity, and if you don't push in and things like that, this mass rollout that we're going to achieve, just can you work us through how is the control? Are 80-year-olds going to be done before 70-year-olds? I understand the scoring, but what is the thinking around keeping the discipline on who gets the vaccine?
Yeah. Do you want me to kick off?
Yeah.
I don't know if I really can answer that, other than what we kind of have discussed at our meetings, and the kind of feedback that we get at those meetings from the Department of Health is that there is a fairly kind of rigorous system to kind of ensure that there isn't. But having said that, we know that there's been jumping of the queue with the healthcare system register. We know that. We know that people that are not eligible have been registered, have been going to, and getting vaccinated. So it is certainly very far from being a foolproof system. So, I'm not sure I can really kind of comment much more than that. I'm sure both Ron and Stavros will be, in fact, a better position than I can from our point of view.
Stav, do you want to have a shot at that?
Sure. So look, let me firstly confirm what both Barry and Ron said earlier. The EVDS system hasn't been opened up for phase 2 as yet. We got that confirmation today, in fact, from the person that's got the management and oversight of the EVDS. I think you can take that SMS as a scam. Then I guess the question here is, how do you prevent some of the fraud and queue jumping that is inevitably going to take place in phase 2? And I think we've been asked the question a lot of the time, well, if you couldn't control it in phase 1, what are the prospects of success in phase 2? So I think that there are many lessons that have been learned along the way with respect to phase 1. There is going to be a very serious attempt to plug some of the gaps, and more particularly to allow better sequencing when the appointments are set up. It's going to be an appointment system. I must hasten to add, however, that in my experience, probably the area that requires most immediate attention, and I think Ron's quite close to this as well, and I'm sure you'll invite him to add additional comments, but the area that probably needs the most attention and focus right now is the EVDS system. And frankly, why Israel's been so successful is because I think they got their RT right up front. And you're only going to be as good as your RT. Now, I think we've made some significant progress, in my opinion, on the EVDS system. If I compare it to around those early meetings we were in January to the system that we've got now, there certainly has been progress. But there's a lot more to be done, Howie. And I have no doubt that we will continue plugging the gaps as we go along from mid-May.
So, Ron, let's be very specific. You wear many hats in this. You're involved in Business for SA, but you're also Chief Commercial Officer of Discovery Health. So let us presume that I'm one of your members. How do I register? Do I register on the government EVDS system and at Discovery, or do I register only on one and somehow you pick me up? Tell me what the process is for your members.
I mean, I think, firstly, I hope that you're a Discovery Healthcare member, and you'd be delighted to support you on the journey. I think the first point to make there, Howie, is that you need to register on the EVDS system. The EVDS system is the national system that will generate an authorization code for your vaccination. And I think to Stavros's point, we would be delighted if the EVDS system does that and does that well, generates an authorization code. And that authorization code, you wouldn't be able to access vaccination without that authorization code, whether it's in the public sector or the private sector, which maybe goes a little bit of a way to answering your question, Benji. Insofar as the Discovery system, what we've done is firstly, we've segmented the entire Discovery base. So we stratified the entire Discovery base based on age and then your underlying medical condition. So the prioritization that Prof. Schoub talks about, we've already done across all Discovery Health members. So if you're a Discovery member, you're already in a virtual queue across our system. And we stand ready to upload that set of data into the EVDS system if that were allowed. Unfortunately, that's not an option at this stage. What the Discovery portal is designed to do is to enhance the journey for Discovery members, and bearing in mind that Discovery members include the Discovery Health Medical Scheme plus a range of other schemes, so BankMed, LA Health, Remedy, SADMAS, and so on and so forth. So this journey is designed to give Discovery members additional functionality, including booking functionality, including second dose reminder functionality, including a vaccine certificate, an electronic vaccine certificate, which I think is really, really important as part of this journey. So it's and a supplementation to the EVDS system. Unfortunately, you will need to register on both. EVDS is a must, and Discovery, if those additional features are attractive to you, we'd be delighted to help you with that journey.
So can I presume that Discovery themselves will be running their own vaccination centers for members?
Yeah, so as communicated by Adrian in the note, I think a week and a half or so ago, we've been working alongside our partners at BFORS on this initiative throughout, and have made a commitment throughout to add to the national vaccination capacity through Discovery run and operated sites. And those sites include Discovery offices, Discovery stores, and we have various other sites that we'll be able to inform you on over the next week or so.
Give us some examples. Can you tell us some examples of where are they likely to be? Durban, East London, Port Elizabeth, Pretoria, Johannesburg. Give us some examples of the sort of places that you want to use as a site.
Yeah, I mean, so I guess a few examples, as I mentioned, the Discovery offices. I can conclusively say one Discovery place in the middle of Sandton will become a vaccination site. Our intention is to convert one or two floors there to enable the Discovery members to get vaccination there. Our office in Cape Town will become a vaccination site. We're working with a few convention centers at the moment to lock in some sites there. And then a few of our other retail and fitness partners, which I'll be able to fill you in on in the next week or so. So those will all become Discovery operated sites. I think importantly, Howie, those sites are available to Discovery members, non-Discovery members, and the public more broadly. So they're not exclusively Discovery sites. We will set them up with sufficient capacity to ensure that we're able to vaccinate efficiently, and that the journey is a good journey for all people who decide who access those sites. But those sites are part of the national database for sites as well.
So just talk us through, if I'm a Discovery member, I come to one of your sites, do I pay for a vaccine? And if I bring with my domestic worker, does my domestic worker pay?
Yeah, what a great question. So neither of you pay for the vaccine. I think the principle around vaccination in South Africa is that it's free of charge to everyone. if you're a medical scheme member, it's funded by your medical scheme. So Discovery, for example, would fund both the vaccine as well as the vaccination. If you're an uninsured citizen, we're currently working on a solution with National Treasury and the National Department of Health to set aside some funding to enable vaccination for uninsured populations in private facilities. We feel quite strongly about this initiative, not only at B4SA, but also at Discovery, that this pool of funding is critical for us to fully leverage your private sector capacity for uninsured populations to access vaccinations at your private sites. But the answer to your question is, so long as we're able to get that right, then these sites will be open to everyone and fully funded for everyone.
Just before you go, there will also be people, of course, who are not Discovery members who are busy watching. I'm sure, Ron, your intention is to get them to change. But Stav, you probably have some sort of view of what's it going to be like for Med Scheme members and for ProfMed members. Are they planning similar sort of initiatives to that being planned by Discovery?
So, Howie, to the best of my knowledge, I'm not aware of any of those other schemes and or administrators that have got as advanced plans as Discovery. I think many of them are talking about it. They might be keeping their cards pretty close to their chest, but I think the Discovery, the Discovery initiative, I think, is the most advanced. But having said that, Business for South Africa has a well-established, what we call a service delivery platform that is populated by appropriately skilled personnel. These are all volunteers, of course, that are looking to integrate the various private sector provider groupings and or networks to get them all integrated into one coherent vaccination, if I can call it vaccination machine almost, because that's what we're going to require here. So this will involve all your corporate pharmacies, your independent pharmacies, travel clinics. There will be mobile clinics eventually that come into play. And of course, your hospitals, your GP practices. That's the network that you can expect. And we've done quite a lot of work around this, and we believe we can get to around 150 to 180,000 patients vaccinated on a daily basis in the private sector. So that gets you a sizable chunk of what you need in terms of the 250 to 300,000 that we're looking at.
Sorry, Benji, sorry, Stav, I interrupted Benji. I know he had a question.
No
so
no, just are you going to?
Can I just say one last thing?
Sure,
Sorry, a little more precise, and I'm sorry to take you back to the EBDS, but because I see there quite a few comments coming through on the chat group. There's nothing worse for a campaign when there's misinformation and people lose interest and give up. So we don't want them to do that. So the date we've been given for when phase 2 registration can start taking place through the EBDS is the 16th of April. So I'm reading a lot of the comments, and I don't want people to become demotivated because, there are different dates and start all of that. So the official version we've been given from DRH is the 16th of April. I'm sorry to have taken you back. We can move forward now to what you were going to ask, Benji.
No. I think it's a very important point because, we're already up to 78 questions, and a fortune of them are on the EBDS and about registering. And so I think that message is very important, Staff. Thank you for that. You're going to arrive at a vaccination center, Ron. Are we going to be able to choose which vaccine, if you want a Pfizer or J&J, or is that going to be predetermined?
Yeah, I kind of always revert to Dr. Fauci's answer on this. He was asked exactly the same question 2 weeks ago on a late night chat show, and in true Fauci fashion, said he would take any vaccine that was available at the time, whether it was Moderna or it was your Pfizer, which are available in the US. And I think the same thing rings true in South Africa. The J&J vaccine is an excellent vaccine. The Pfizer vaccine is an excellent vaccine. We take whatever is available at the time. I think South Africa is actually in a very privileged position, in my view, to have two of the leading vaccines globally.
So you're going to arrive at your place. If there's J&J, that's what you take. If there's Pfizer, that's what you take, and kind of that's the way it's going to work. A lot of questions are coming through. If you have comorbidities, is the plan for Discovery to reach out to you and say, come in now? And if you're under 60, if you don't fall into the age category, is that the plan?
Yeah, exactly. I mean, I think what we have recognized throughout this COVID pandemic is that information is key, and there is a lot of confusion out there. And I think we feel it's our obligation to mitigate confusion, communicate clearly around the process. As I said to you, we've already segmented the Discovery base. We know where you sit in the virtual queue. That allows us to send out communication at the right time and at the right cadence to make sure that you're well prepared and you're well informed as part of the journey. We'll do that in tandem with the national rollout process. So the timing will work in sync with that. But certainly the intention of our portal is clear communication and clear instructions as part of that.
And the national rollout, that's the plan as well. That if someone's under 40, someone will reach out and say, come in for your appointment if you fall into those comorbidities.
Yeah. And I must just reassure everyone on the call. My wife, as a frontline healthcare worker, has just gone the system for frontline healthcare workers. I think she got the sum total of 9 SMSs throughout the journey. And certainly it's our hope that EVDS works on a similar basis at scale. You get SMSs before, day before, hour before, slot before, afterwards. We're certainly hoping it's going to work in a similar way. And at the same time, we'll put the Discovery system to enable that sort of communication.
But Benji, if I could just comment on your question that you just had, within the public healthcare sector, there's no centralized database. Discovery or the other medical insurers in the private sector sit on your data. Because there's no electronic record in the public healthcare sector, there's no way of determining who you are, what comorbidities you have. There's no way they can reach out to you. So it's going to be very much dependent on people to disclose that degree of information through when they fill out their form, their electronic form. And stuff, there's been questions coming through to say, this is very first world, filling out electronic forms. What about the people who don't have access to the internet? What about people who don't have access to data? What are we going to do for those people in this country?
So, Howie, I think firstly there's a question, what does EVDS stand for? It stands for the Electronic Vaccine Data System, right? So already the name's off-putting to people that don't or are technologically inept, right? Or don't have proficiency in technology. But I think what is quite surprising, and Ron is probably better suited to answer this question, I think, but what is surprising is that a vast percentage of the population actually have access to mobile technology and are quite adept at using it. In fact, we found this, and the mobile technology has been very successfully used in, for example, the ARV, the public sector ARV rollout program. So we supply every month as a country around 5.5 million lives with ARVs on a monthly basis, and a lot of it is technology driven. And much of the public sector that receives these medicines on a monthly basis are actually people that you wouldn't expect to be that technologically adept. Now, I think Ron might want to complement or supplement what I'm saying.
Yeah, it's such an interesting question. We had this debate over the last few days on the Discovery portal. And the ingoing assumption was that our more older population was less digitally savvy. It actually proved the reverse is true. In fact, we have very high digital usage in our older population groups, and I think I have a high degree of confidence that our elderly members will be able to navigate the system quite comfortably. And if they're not able to navigate the system, they certainly have family members that will help them to navigate. But it's been quite a pleasant surprise for us how digitally savvy. Certainly, our discovery members are across the spectrum, but even more so in elderly population groups.
So if we can turn to Barry for a second. Barry, you're looking fantastic, I must tell you. But despite that, my presumption is that you're above the age of 60. I may be completely correct.
Just above that, just above
that. When realistically do you think you will be vaccinated?
Can I maybe just explain what Stavros was saying? ARV is antiretroviral therapy for HIV, just for the listeners who also were querying that one. Okay, I am a healthcare worker, as you probably would guess, although I'm not a frontline one, so I haven't been vaccinated yet. My wife's also a healthcare worker, also not frontline, also hasn't been vaccinated yet. So I've registered, and I guess I'm waiting. There's no way I want to kind of jump the queue. I probably could, but I will certainly not do that. And when my turn comes, it'll come.
So let us presume we have someone who's watching, who's 90 years old, not a healthcare worker. When realistically do you think that they will be vaccinated?
I think they'll be top of the queue probably in the middle of May.
Middle of May.
That's when I'm hoping the phase 2 is going to roll out.
Now, I can say that Ron and Stavros don't look as good or as young as you, but my presumption is that they are under the age of 60. So, Ron and Stav, when do you think you will realistically be vaccinated?
First want to ask Stavros whether he's going to take the Pfizer vaccine or the J&J vaccine.
I'm going to give you a Fauci
answer. When it was produced.
Ron, I'm going to give you a Fauci answer. I'm going to take the vaccine that I get. So I think, these are all excellent questions. They're very relevant questions because there's a lot of anxiety out there, particularly as we anticipate a much dreaded and hopefully a muted third wave. But I think the odds are good that you will get a third wave. And as I say, hopefully it'll be a muted one. But so it's understandable why people are getting anxious. But I think what we need to probably say at the outset is we've been through this pandemic for 14, 15 odd months. It's been very uncomfortable and pleasant. And I think we are starting to see light at the end of the tunnel in that we have started landing vaccines. And I think we've got to hang on a little longer. I know patience is sort of very thin at the moment and all the rest of it. But I think we don't have that much longer to wait, certainly for the high-risk populations. So let's work on a start date of mid-May. If you
but Stav, you don't honestly think I'm going to allow you to not answer my question.
Okay,
when do you think you will personally get vaccinated as a youngster of your age?
Okay, so firstly, I'm in the category of 55 to 60, right? So let me declare that first.
That Botox is working.
I think it's a good lighting.
It's the collagen. It's the collagen.
It's more the bad lighting here, I think. But so I'm also a healthcare worker, right? But not a frontline healthcare worker. So I would anticipate, given the scale at which I think we will vaccinate as a country, I would expect to be vaccinated probably in late June, early July, there or thereabouts. And I would expect the first group that goes in mid to late May is going to be made up of, 60 and above on a sequenced basis. So I think if you are in that age group, I think you can probably expect to be vaccinated over the first 4 to 6 weeks from the start date of mid-May, if you're in that group of 60 and above.
But let's talk about the people who are 36-year-olds, non-healthcare workers. Ron, when realistically should a 36-year-old engineer expect to be vaccinated?
Yeah, I mean, it depends on how many people across the population we sit in the virtual queue. I think the starting point for that question, Howie, is that we've got sufficient vaccines scheduled for South Africa to get everyone vaccinated this year. And I think that's an important starting point. So we've obviously secured 20 million Pfizer doses. We've secured 31 million J&J doses. All of those doses land in South Africa in 2021, which gives us the ability to vaccinate 40 million people. What we've got to do, as Stavros mentioned earlier on, is we've got to vaccinate fast now. And when you get vaccinated will depend on how quickly we can vaccinate both across the private sector as well as the public sector. I can tell you that Stavros, myself, Barry, are working extremely hard to increase that capacity. And that's a big part of the reason Discovery's invested in additional sites. And many of our business partners have invested in additional sites. Pharmacy groups are opening up their sites so that we can really open up the pipeline to vaccinate fast. If you're a 36-year-old, depends where you sit in the population queue, and depends on how quickly we vaccinate.
So I'm sorry, guys, you're ducking and diving. And there are thousands of people watching us tonight, and I think one of the lessons that you should have all learned is that the failure of our government, the failure of our medical insurers to communicate with the people of this country has led to an enormous amount of distrust. And tonight is the night we break that distrust by saying, stop avoiding the question. Allow people, tell them the truth, and people can manage expectations based on the truth. But to not answer the question that I'm posing tonight, which is the most crucial question for everyone who's watching tonight, when can they reasonably expect to get a vaccine? If we don't answer that question, I'm sorry, you have all failed the people of this country. So I'm going to pose that question again. Realistically, Ron, if I'm a 36-year-old factory worker, when realistically can I expect to get that vaccine? Give me an honest answer. And if you can't, tell me you don't know, but stop ducking and diving.
I mean, I'm going to be honest with you. If you're 36 years old, I can't do the calculation now and when exactly it'll be. What I do know is if you're a 36-year-old and you don't have any comorbidities, you will fall in phase 3, which means that we've got to first vaccinate 15 million people in phase 2. And in phase 2, we should be able to get through phase 2 based on your current supplies by somewhere around the end of July, beginning of August. So phase 3 should be on the horizon towards your middle of August. So to answer your question as conclusively as I can, it'll be after around about the middle of August, based on your projected supplies and your projected throughput capacity. I think importantly, what we're focused on right now is getting through the population groups over the age of 80, over the age of 70, conclusively is across the Discovery membership base. We know exactly who they are, where they are, and our priority is to get those groups through vaccination. That includes my parents, grandparents. That really is our focus.
But I think, you can't manage, I'll come to you in a second, Barry. You can't manage what you don't know. And distrust comes from the lack of information. So I think we have to be much more confident to take the confidence of the people of South Africa and say, look, if you have no comorbidities and you're 32, chances are you're in November or December. And people can manage that, but they can't manage the unknown. And that's a lesson that I think we've all learned in our own businesses. But I think, Ron, you've seen distrust happening amongst your own members from the lack of information. I think you see the comments, Barry, of people in the newspapers. It's the lack of information that leads to distrust, and we have to break that. Sorry, Barry, you wanted to say something.
No, Howie, I think I can sense your frustration, which I think is a frustration amongst the entire population. And that frustration is born of the fact that there are no clear answers. Finished. There are no clear answers. I know that there's an expectation to get a clear answer, but the one thing I can tell you is that even when the vaccination program is well advanced, it's not going to switch off the epidemic. We're still going to be vulnerable to kind of cycles of epidemic. There are two issues, there are two kind of aims, two goals for the vaccination. The one is protection of individuals. And individuals, obviously the individuals that are the highest risk, they come the highest priority. No vaccine is 100% effective. No vaccine, even the measles is bad, measles and polio, all those very successful vaccines are far from being 100% effective. Even our COVID vaccine, we're talking about 90%. If you talk about 90% of efficacy for severe disease, means you've got a 1 in 10 chance of getting severe disease. Obviously, it's going to be modified by other factors such as exposure, morbidities, and so on and so forth. So the expectation of the public must be kind of tempered by some sense of realism that first of all, self-protection of individuals is not 100%. We've got to rely basically on community protection. We want to kind of dampen down that circulation of the virus. That's going to take time. That cannot happen immediately. That can only take place once a certain percentage of the individuals are immunized, plus, very importantly, that the human behavioral, all those kind of elements that we talk about so much about preventing infection are still in place once the vaccination program is rolled out. And I think we need to kind of look at those as kind of realistic expectations. We're not going to switch off the epidemic. That virus will not disappear. We've only made one virus disappear in the world, that's smallpox. Neither virus, neither infectious agent is going. So it will be there, even despite the vaccination. We still will have to kind of have some kind of infection control procedures to assist, to supplement vaccination. I think that's just an important point. I think it must get out there to the listeners.
This might seem an obvious question, but do you have to finish phase 2 before you start phase 3, or will there be, depending on like what the take-up is and things like that? Is that part of the confusion and the complication here? Is that you're not sure how long phase 2 is going to take?
So I can sorry, go ahead, Barry.
Go, Steph.
Okay, sorry. I just wanted to reinforce a couple of points here. I think Harvey's quite right in that rather give people the bad news and under promise and over deliver later. And I think we all fully subscribe to that mantra, right? I think Barry is also quite right in saying that the environment's exceedingly fluid. So I can give you the breakdown right now. So you asked me when I thought I would be vaccinated. I've given you a sense. Can I put absolute hand on heart that it will be late June, early July? I can't. What I can do, however, is let me give you the timelines that government has communicated, and I'll give you my sense of whether they're realistic or not, right? So we know that phase 1 will be completed by mid-May, because just a question on the chat group saying, well, can it be that all healthcare workers won't be vaccinated by mid-May? Okay, the plan is that all patient-facing healthcare workers, a guy like me who never sees a patient in his life, doesn't deserve to be in that first group, right? So I think you can take it as a reasonably safe bet that most, if not all, healthcare workers that are patient-facing will be vaccinated by mid-May. Okay, then the plan is from mid-May onwards, so what we call phase 2, which is around 17 million people, citizens, as I said earlier, phase 2 commencing in mid-May and ending between end of October and mid-November, which is intended to cover these 17 million people. Let me tell you who the 17 million are again. It's 2.5 million essential workers.
Who is an essential worker? Because we've had a number of teachers, for example, asking if they considered essential workers.
Yeah. Okay. So I'm just giving you who's in phase 2, right? I'm not giving you the sequencing. I'll come back because we're clear that on the sequencing, we're going to go elderly first and then work our way down, right? So essential healthcare workers are policemen, correctional services, teachers, those type of public servants, if I can call it that. And it doesn't include at this point in time, because I know where you'll go to with your next question, I suspect, where do people like cashiers in supermarkets fit? Because I think the retail sector's made a very compelling case, saying, well, their frontline cashiers have a significant exposure. So that is, at this point in time, is not included, that category is not included in essential workers. So let me give you the rest of who's in this phase 2, right? So it's 2.5 million essential workers, about 1.1 million people or persons that work in congregate settings. People that are age 60 and above are around 5 million people. And then persons that are 18 and older but have at least one comorbid condition, if not more, number around 8 million. So that takes you to your 17 million. The plan is on a sequential basis, according to your risk stratification, you can be expected to be vaccinated by mid-November. Okay, now let me get to the 36-year-old engineer. Now I'm assuming this 36-year-old engineer does not have any comorbidities and is a healthy individual, right? Phase 3 will commence. Phase 3 numbers 22 million citizens, will commence from mid-May and will end sometime in Q2 2022, right? So if I'm a 36-year-old, perfectly healthy guy, I would be expected to be vaccinated in Q1 of next year. So I would be pitching my bet in about March next year, there or thereabouts. Okay, now, I don't want you to take these as absolute dates. These are the planned dates. It's going to depend, of course, on our ability to ramp up and escalate our capacity in the country. And I have no doubt that at a point in time, the machines will be firing on all cylinders and we will get to that aspirational, as ambitious as it might sound, 250 to 300,000 lives. When you're in that rhythmic flow of things, if you think about it, if you're doing 250,000 patients a day, you're doing 1.5 million a week, then you can see how the trajectory starts going up. So I wanted to give you the guidance, if I can call it that, of when you can be expected, but I'd hate for the next webinar, this 36-year-old says, well, I got vaccinated in May and it wasn't in March. You'll understand why. So
I think people understand the fluidity, but they need some certainty,
sure,
somewhere and some information. Benji, we probably have about 12 or 13 minutes left, and there are literally hundreds of questions that have come in to the Q&A section and to the chat section. I'm going to ask, there's some questions that we want to get through, so I'm going to ask everyone to be really, really quick, and we're going to ask all our panelists to look in the Q&A section as well and maybe pick one or two answers. But Barry, the question that comes up time and time again is the issue of the flu vaccine.
Yeah.
Should people be going for a flu vaccine now?
They should be, yeah, because flu vaccine is essential. It's an essential supplement to the COVID vaccine. There should be about a 14-day interval between flu and getting the COVID vaccine, but you should get both of those. Yeah.
Let me just ask again about, we asked the question last time, is there any reason why you wouldn't have the vaccine? There's so many posts about this illness or that illness. Are there any reasons why not to have the vaccine?
The only reason for the COVID, you're talking about the COVID vaccine, the only reason for the COVID vaccine is if there's no absolute contraindication. It's just that if people do have a history of being allergic, so they should notify and they should alert the vaccinators to that case, and they should kind of wait an additional period of time after being vaccinated. But other than that, there's no absolute who shouldn't get vaccinated. No.
We've asked this question before, but people can't have, maybe talk through, they can't have one shot of Pfizer and then the J&J. They have to have the shot. Or if we get Moderna or other vaccines, they have to stick with the supplier, one supplier.
Well, now let me amplify that. Yeah, basically the trials have obviously only been done with the same vaccine, and therefore what the regulatory authorities have regulated for is to have the same vaccine. from a purely medical, biological point of view, there's no reason to actually not mix them. And it may well be in the future that will be relaxed. But as it is, the kind of reassurance from the trial data is to have the same vaccine. And that's what is part of the regulatory authority.
Stavros, if I could just, my ex-boss, Judge Johan Krechler, has asked a question, so I feel a moral obligation to my ex-boss to actually ask him. There are a lot of people in South Africa who are undocumented migrants or illegal in South Africa. Are we going to be providing vaccines to them as well?
Yes.
Yeah. Okay. Cool.
Can you talk, Barry, quickly just through Sinopharm, Sputnik, all of those vaccines?
Yeah, we've been in a lot of discussions with both the Sinovac and the Sputnik, and from the Gamaleya Institute. There are a number of queries, a number of issues we just need to have clarified with both of those vaccine manufacturers. So we are at this stage in discussions with them. Neither of the vaccines have been registered, although they have made application to SAPRA, but neither of them are registered, none of them are licensed for distribution as yet. But we are in continual discussion with both of those.
So your advice is, if they're registered by SAPRA, enough work and evidence has been made, you should feel comfortable with it.
Yeah, they've been rolled out in many countries around the world. The biggest question, of course, is how it behaves against our variant, against the 501v2 variant. That's the big question.
Right.
And we don't have data to that effect.
Okay. Maybe Stav, if you could answer. I'm an employer, and I've got big employee groups. How do I assist? How do I help you guys? Is there a way that someone who employs lots of people can assist, get their groups vaccinated? I don't know. Talk me through how we can assist as an employer.
So, Benji, I think that's an excellent question as well, because there's so many South Africans that want to contribute, and it's really heartwarming. And I think we could have a webinar on its own on some of our own personal experiences, which are really heartwarming, particularly at a time of crisis. So I think that big businesses with lots of employees can assist in three ways. I think the first thing is if we can assist to communicate a clear, concise, and accurate message, which is really where Howie was going. And I think if we take anything out of tonight's webinar, it's probably that point, Howie, that we need constant, clear, concise, and accurate information. So to the extent that employers can assist with that, it's going to be immensely helpful. Whether it's even, one of the most important things I heard this evening was from our Israeli colleague that said, they've vaccinated vast swathes of their population, and they've actually had very little adverse events, if any, I think he was saying, right? Something to that effect. Now, those are all important messages that need to be amplified out there. And if you've got a particular catchment audience, as an employer would, an employer with vast, with many employees, I think those are important messages to get out there. That's the first thing. The second thing is, to the extent that businesses have got occupational health facilities and can make those available to particular catchment areas, that's going to be immensely helpful, because that will form part of the rollout configuration that we're looking at to scale up to, right? And then the last thing is that to the extent that funding or donations can be made towards the Solidarity Fund. The Solidarity Fund is still open for business, a slightly different mission this time around. They are collecting funding, and part of that funding will be distributed in time to those that require healthcare services that cannot readily access a vaccine. They will assist. So it's a bit of a contingency, if I can call it, war chest, if you want to call it that. But the SF is looking to build that up. Those are the three most immediate areas I would look to contribute towards.
Right. Ron, could you maybe talk through what the sites are going to look like? Are they going to run 24 hours? Have we learned some in your planning or through Business for South Africa?
Benji, I have a much more important question that Ron has to answer before answers that.
Yes, vitality points.
Vitality points. Will I get vitality points if I get a vaccine?
Yeah, so the answer to that is, I mean, I think vitality points are designed to drive the right behavior.
Miles.
And my expectation is, we shouldn't have to give vitality points for getting a vaccine, because it's definitely, this is just such a no-brainer. In fact, my personal view is we should be taking away vitality points if you don't get vaccinated.
Exactly.
But we are working on vitality points as we speak. We'll be able to let you know about that in the next few weeks. It is a piece of work we're doing at the moment.
Can you talk through what the site will look like? What the actual vaccination sites?
Yeah, thanks for that, Benji. I mean, I think firstly, we learned an enormous amount from my colleagues at Maccabi. So Ido spoke a little bit earlier on. We were speaking to Ido way back in January already, and learned a lot from the different sites that they had set up and the processes they had set up around the vaccines. As I mentioned earlier on, these will be pretty large sites. They will be designed for operational efficiency so that you're able to maximize your throughput time. Specific regulatory requirements or steps basically would be a registration station, a place, a waiting area where you do your consent, then into a vaccination booth to receive the vaccine. And then a very important step afterwards is a 15-minute observation time. That observation time is designed to watch for any potential adverse events. As Barry says, they're very, very rare and few and far between. And we certainly are thinking about some interesting parts of the observation time. I mean, I think I would like to make that an interesting time for Discovery members. Not just sort of sitting around twiddling thumbs for 15 minutes.
Ron, will they run 24 hours?
I don't think so. I think these are going to run sort of the optimal capacity is to run them on a 12-hour shift. So 12 to 14 hours a day is what we're seeing, and then you run 2 shifts in a day, so that gives you operational efficiency for those of you know your operations. The intention is certainly to run them 7 days a week. So we don't have time to spare, and we certainly want to run as fast as possible. So not 24 hours, but certainly 7 days a week.
And is there a process if you haven't utilized like the vaccine in a certain time to contact others and get them in and to make sure that there's no wastage?
We don't want to waste vaccines. So we're certainly going to have initiatives like that. Last hour special so that we maximize every single dose. This is meticulous stuff. In a Pfizer vial, you've got 6 doses. Can't afford to waste a single dose, whether it's at the end of the day or half a vial, inaccurate measurements. So certainly.
So our 37-year-old engineer who created quite a consternation tonight, just morally, Prof, if he's waiting in the queue at the end of the night and there's an available vaccine, should he take it?
Yeah, I think this is it. You don't really want to waste vaccine at all. Vaccine is such a precious commodity. And I think that if there's nobody else in the queue and there's a 25-year-old healthy, fit weightlifter, I think it should be going to that person's arm if there's nobody else around.
Exactly, Stavros. So if I can ask all our panelists just to look into the Q&A section and just select one last question that they would like to answer. And Stav, if I can just pose a question to you while everyone does that. For a lot of business owners, the question of bringing people back into the office is a very crucial question. Is this the right time, in your opinion, to start bringing people back into the office, either full-time or part-time? Or if people can still work from home, should the preference be that they continue to work from home and not be in a congregate environment like a workplace?
So, Harley, look, firstly, I think it becomes very much an individual company decision. I know at Aspen, we've had the same discussion umpteen times. I think the general consensus is that until we get a vast quantum of people vaccinated, and you are able to efficiently and effectively work from home, you should continue to do so. There are certain businesses, I understand, where you have to be client-facing, and that's a different discussion. But I assume you're referring to those type of businesses that are largely office-bound. If you can work from home, it is still the preference. I think we still need to act with utmost circumspection here, in that we must do our best to prevent a third wave that not only causes significant amounts of demotivation again, because every time we have these waves, the population becomes demotivated. Well, is there ever an end to this? I think we are starting to see light at the end of the tunnel, like I said earlier. If you can take measures to prevent that third wave or to mitigate or modulate it, then you should be doing that. And working from home is one of those areas that would make a difference.
Right. Barry, have you selected a question?
Yeah, I have. I actually, it's two questions, but two questioners, same question. How long does the vaccine immunity last? It's very early days. Of course, we don't really have a definitive answer because we've only been vaccinating worldwide for about 6 months. They've traced good immune responses up to about 6 months, but it's going to be much longer than that. How long it is, obviously, we'll have to kind of wait and see. I think we can project that it's going to be at least probably a year or even longer than that will have good immunity. And that includes, by the way, the single dose of J&J vaccine. We can see even at 6 months, there are very high levels of protective antibodies. I know there has been a bit of widespread publicity for one of my colleagues saying that you need a second dose because it wanes after about 70 days. That's wrong. That is wrong. I don't know why I said that. That is incorrect. At 70 days, in fact, you get very high levels of protective antibodies with a single dose of J&J. So that answers that. Thank you.
Thanks. Ron, have you dipped into the lucky packet and drawn something out?
Yeah, I've certainly had some feisty questions this evening. So, I have dipped into the lucky packet. I think there's one question around why Discovery is going to open up their sites to non-Discovery members. I think the answer to that, as we've done throughout the pandemic, it's the right thing to do. I think it's part of our value system. Contributing to South Africa. We've done enormous work throughout the COVID pandemic. We will certainly create sufficient slots for Discovery members as part of our program, and certainly have a bespoke journey through this, and we're going to support in any way we can. But if there is a way for us to help the uninsured population in particular, we certainly want to be able to help around that.
Thanks, Ron. Steph, what's your Easter egg pick?
Okay, so I'm going to respond to two. The first one is so that I don't get lynched in the next couple of days. So the question is, why have pharmacists not been, these are frontline pharmacists, not been vaccinated? One says, I'm not sure why, because they are eligible. And I would suggest, I'm not, there seem to be a lot of pharmacists on this call, and I'm assuming they're community pharmacists. So I would be speaking to ICMA if I were you, because you certainly are eligible. You're in the next group that goes. So that would be my response to that. I think the final issue I wanted to cover is more an economic one. There's been a couple of questions around, are we borrowing money to save lives? And there was something about the BRICS Bank loaning money, etc. So I think maybe to put a slightly different spin on this, most of the viewers this evening would know that the private sector did make various attempts, primarily through Adrian Gore. These are ongoing discussions where the private sector contributes a 1-for-1. So one vaccine consumed in the private sector, you then fund an equivalent dose in the public sector. And It wasn't through lack of trying, and there's ongoing attempts to get that right. But the response from government right now, specifically from Treasury, and I sat in those meetings with the President, the Finance Minister, the Health Minister, etc. The feeling is that this is one of the best investments government will make, so they will pick up the tab regardless of what it costs. And you know what? I can't disagree for a moment, because there is no better, I think I said this on the last call, Benji and Howie, there is no better economic recovery plan right now than to vaccinate huge swathes of the population. If you get that right, you open up the economy a lot quicker, you can get back to economic recovery and growth. So I think that would be my perspective on that question. And hopefully I'm not going to be lynched by the pharmacists. I'm one of them, Howie.
Benji, just before you thank everyone, I want to give a word to Barry Schoub, because Barry, we're all going to land up with a vaccine in our arms at some point in time, whether it's a week away or a month away or 6 months away, but we're all going to be vaccinated. The question tonight is not, do we have enough vaccines? We've bought enough vaccines. It's just when we're going to get it into our arms. But I want to talk about the day after. What do we do behavior-wise the day after to make sure that we actually defeat the pandemic?
Yeah, Howie, to answer your question, I think basically you've got to realize the vaccine is part of the solution, but not the total solution. In other words, that you do have to supplement vaccination with behavioral changes. And I hope that we will retain some of these infection prevention procedures. It's going to educate us, not only to prevent COVID, to prevent flu, to prevent other diseases as well, hand sanitizing, even wearing a mask if you've got a cold like they do in the Orient. I think those are good habits which I hope we will retain. But of course, the vaccine is obviously the major way in which you're going to control the epidemic. So to answer your question, what do you do the day after? I think the day after, I think you realize that you're partially protected, not totally protected. You still have to kind of, until the epidemic comes completely under control, still retain some of those infection control procedures.
So Benji, I think there was a lot of good news tonight. Some of the good news that we maybe hid a headline was, Stav, your facility, you're going to be in production. We're gonna have J&J vaccines out of Aspen much sooner than we anticipated. You spoke about April. You said to us in our last webinar that you were only anticipating maybe June or July. So there's fantastic news that you guys are in production. And I think the other good news
remember what I said, rather under promise and over deliver.
Howie, that's why that engineer, buddy, he's getting vaccinated much sooner than we all think.
No, but I think part of the other great news is in fact phase 2 is starting much sooner than people anticipated as well, and that we're a week or two away from people being able to register properly to get a vaccine, and we'll probably have 6 million people vaccinated June, July time. That's fantastic news that we can't lose sight of it. And I think people understand this is a moving target, but to have people of the caliber of Ron and Stav and Barry actually driving it for our nation is just such an absolute privilege to be able to have people of this caliber that we can actually put our trust in and make sure that things actually go in the right direction and are happening much faster than we ever anticipated. So from my perspective, I know Benji's going to do the thank yous, but from my perspective, it's been such an honor to have the three of you back on this panel. Forgive me for giving you a tough time, but we needed to get those answers out. But I walk away with this with even more confidence in our country's effort to make sure that everyone stays alive, stays healthy, and until then, stay masked and stay sanitized.
Look, Howie, I don't have much more to add to that other than I've always been an optimist and I'm cautiously optimistic. I've experienced, especially Stavros and Professor Schoub, and I know the kind of work that Dr. Ron Whelan has done. And I think, please God, this is going to roll out quickly. These phases are going to hopefully once we get going and the momentum starts, as you heard in Israel. And I couldn't endorse more how you and I have both been on that business for South Africa. Those work streams are detailed beyond belief, the kind of effort that all these people are making for the citizens of South Africa, no matter who they are, no matter what they are. It's just an absolute privilege. And the one point that if we can help, at all stages, just to provide information, to provide actual information and to assist, we're making that offer to you. I know we've made it a few times, and we really just feel completely committed to this country and to make this work. This is I heard you say, Stav, this is the biggest undertaking that South Africa has ever taken on, to vaccinate 40 million people. In Israel, they vaccinated 5 million, which was an amazing achievement. And just thank you so much. It's 10:10 at night, and you guys are still here taking all the abuse, and we appreciate it so much. And if we can help in any way, we're just a phone call away. Thank you so much.
So to all the people who are watching us, and we still have thousands of people watching us between the various channels tonight, please do us a favor, just give a letter of thanks, a note of thanks, if you can put it into the chat section here or the chat section on YouTube or on Facebook as well. Just give a word of thanks to the remarkable people that we have on this panel, to really the professionals that are driving your safety in South Africa before you log off for the night. So to all our panelists, to Ido, who's left us but is in Israel, to him, thank you. Barry, you're always available. Stav and Ron, you never say no to any requests that we make. And our absolute gratitude for all of you, for everything you do for us, but more importantly, everything that you do for the country. Good night. We'll be back and see you on Monday night with another remarkable webinar that we'll let you know about over the next few days. We're going to play out with our little jingle about the Jewish Report. Don't forget to leave us a comment. If you're watching on YouTube, please press like and subscribe. That just helps us communicate with you a little better. We'll see you on Monday evening. Good night to all of you, and thanks once again.
Thanks very much. Thank you.
Thanks very much.